All right. Well, hello everyone, and welcome to our part one of our gut brain mini series. And we are so excited to have you today. We're thankful that you've all joined us, and we are welcoming Dr. Lindsay Moreau to speak with us today. And what I'm going to do, I'm just going to tell you a little bit about her, and then she's going to get going on her talk, which is really talking about the gut brain axis and the perimenopause angle and hormone balance angle with gut brain axis. All right. So, Dr. Lindsay Moreau, she is a certified naturopathic physician. She completed her degree at the National University of Natural Medicine in Portland, Oregon, and completed residency at Progressive Medical Center, a functional medicine clinic in Atlanta, Georgia. Dr. Moreau is currently a naturopathic physician at Ideal Human Chiropractic and Naturopathic in Wisconsin, specializing in treating chronic conditions ranging from IBS to environmental illnesses to infertility. And besides treating patients, Dr. Moreau is also an integral part of the U.S. biotech consultation team, bringing her vast knowledge and clinical insights to the lab team and U.S. biotech practitioners. She has a passion for educating in all forms, from one-on-one consultations to national webinars. So let's give her a welcome. Feel free to put in the chat where you're joining us from, and welcome, Dr. Lindsay.
Yay, thank you. Thanks everyone for taking time out of your day to be here and to committing to learn more with me. So when they asked me to talk about the gut-brain axis, I knew right away that I wanted to talk about it in terms of perimenopause, because perimenopause is super trendy right now. And I'm a sucker for a good trend. So I was like, yep, that's what we're talking about. And okay, a good trend, like the whole diet trend of like, remember how it was like, first it was vegan and then it was paleo, but then that wasn't hardcore enough. So we went keto. And then eventually, yeah, that's not the trend we're looking at. This is a sort of trend like, hey, we're finally gaining momentum here. And this is an area where like medicine in general, like we need to grow. So I'm super excited to be contributing to that. And I'm super excited that you guys are all here, like working to continue to contribute to our understanding of perimenopause and our treatment strategies here. So beyond that, I just feel like it's neat to look at the gut brain axis through that lens, or maybe either the other way around, right? Look at perimenopause through that gut brain axis lens, because I think it captures a lot of what a woman's going to experience perimenopausally, like symptom wise, that's not like an obvious hormone symptom. So what we're going to do today is we're going to start with just an overview of the gut brain axis. I always try to think about things like, okay, what do you see as a clinician? And then what's the technical specs of that? And then we'll go through our hormones, and then we'll kind of circle that background to, okay, now let's apply that to the gut brain axis and what might we do there. So that's gonna be what our goal for today is. So we're gonna start in on clinically, what's the gut brain axis. So we see this all the time where you treat the gut and then the brain gets better too. And you're like, oh, that was nice. I mean, I think 9 times out of 10, like, I'm going to ignore your brain symptoms and treat your gut. And then hopefully your brain gets better, right? That's the gut brain axis at work. We can also see this in research. And I feel like every good presentation has to be full of some research articles. So I started right out with that. It's really easy to find. You can see, oh yeah, things going on in the gut. So LPS can impact your brain. So LPS, in case you're not very good at your acronyms, stands for lipopolysaccharide. That's a bacterial product from gram-negative bacteria. So we all have a little bit of LPS going on, but that's an endotoxin. It's one of the most inflammatory things. So your fun LPS fact is that it is used extensively in the research world. So if they want to create an inflammation model, let's say like they're using rats and they're trying to test it on a new drug to see if it works, they're going to create that inflammation model by injecting them with LPS. And that's how good LPS is at creating inflammation. And so we can see the gut creating LPS can bleed over to the brain because your brain is super sensitive. So it's going to react to that inflammation if your liver can't soak that all up. But we see it going the other way too, right? So we can look at things like traumatic brain injury. So we know that a concussion causes instantaneous leaky gut. We also see that in chronic injury, like something like Parkinson's. We know that that's pretty well associated with chronic constipation. And so we can see that that brain influence also can impact the gut. And again, as clinicians, like we kind of know that, right? Well, we know we can start at one end and work to the other. So that's what we see. Now, what's the actual like nitty gritty of that? So I took this definition from a research article I put at the bottom of the page there for you guys if you want to access that yourself. I thought it was a good paper. So it's the intricate bidirectional communication network between the central nervous system, so the CNS, and the gut. And the gut, remember, has its own nervous system called the enteric nervous system, or the ENS. So, well, what are those modes of communication? So that's what you see in the middle of the diagram between the brain and the gut is we've got our different communication pathways. So the vagus nerve is listed first because it's our number one favorite. So we'll highlight that one a lot throughout the day. We've got our neurotransmitters. So that would be what you expect, right? Things like serotonin, your excitatory neurotransmitters, acetylcholine. You've got neuroendocrine. So for neuroendocrine, I want you to think more of things like cholecystokinin and some of those sorts of hormones. Neuroimmune, obviously that LPS we talked about, that's gonna be part of that neuroimmune communication, but it could also be things like histamine's a big player there. And then hormones. That's specifically sex hormones. So that is why I can choose to talk about perimenopause and the gut-brain axis, is because hormones are part of that communication network. Hormones also can influence pretty much all of those modes of communications. And so that's going to be what we were kind of looking at and pulling apart. Now, well, what does that do? Well, from the top down, so the brain to the gut, the brain's going to be influencing things like motility, secretion. So I call it digestive fire, right? How good are you breaking down, assimilating your food? What's going on with your microbiome? How sensitive are you to pain? And then what's going on in your gut, right? Because like, for instance, your gut makes like what, 90% of your serotonin, and that can travel up the vagus nerve. So like, oh boy, that could have a really big impact on your emotions, your anxiety. But we can also think about, again, a lot of those like hunger satiety signals. Those are going to also influence things like they list as behavior. So those are all going to be different things that we see being impacted by our main communication route. So vagus nerve, neurotransmitters, neuroendocrine, neuroimmune. So those are going to be the ones that we're going to be really looking at, because we're already assuming, because we're in perimenopause, that hormone route of communication is really disturbed. So with these communication routes, it's kind of nice to remember what direction they go. Some of them are pretty unidirectional. So for instance, the influence your microbiome has, making either microbial products or signals, those basically go from your gut to your brain, right? Although, okay, I don't know about you guys, but I feel like every time we're like, this part of the body's sterile, it ends up not being sterile. Like the bladder is definitely not sterile. Like we know that now, right? So I would not be surprised if the brain has its own microbiome in the long run, but at any rate, they're going to be more one direction or the other. So you can always start at the top and pick some sort of communication route that's going to talk down to the gut. You can also start at the bottom, pick communication route that's going to talk more up to the brain. And I think it's important to be fluid between those and know how each one of them works. But the vagus nerve we specifically get excited about because it talks both directions pretty well. It's pretty darn bidirectional. So, okay, and the vagus nerve, right, communicates the two different nervous systems. So it kind of seems like the most obvious route. But the other thing that's really excited about the vagus nerve, which connects the CNS to the ENS, so the central nervous system to the enteric nervous system, is that it's a nerve. And anything that's transmitted by the nerve, those changes are affected very quickly and very directly. And that gets really exciting because now if we work on the vagus nerve, we can directly basically talk to the brain and the gut at the same time. And I think that makes us really happy, really excited. So shout out to the vagus nerve. I think it's also kind of interesting to note that, okay, well, let's say that you're talking to the vagus nerve and you're working on that. Well, that now influences the gut. And then that's going to influence, well, 70% of your gut, well, 70 to 90% of your immune system is in your gut. So now you're also using the vagus nerve to kind of bleed over into the immune system. So that neuroimmune. So even though we've categorized things here into like discrete categories, they're not necessarily all that discrete. And I think in practice, things really do bleed over into one another. So I think that can be kind of important to remember and maybe not get like, be mindful, like don't get frustrated about that. It's okay because it's messy and there's a lot of overlap. So that's the gut-brain axis. Well, what about perimenopause? Y'all know perimenopause. So I think of this as starting like normally around age 45 is kind of what I'd like to see most typically. However, I think we all know we can see changes happening as early as 40. And obviously there's also surgical menopause as well. And that's kind of like, you don't get the perimenopause, but you kind of get all those perimenopause crazies like after the fact if they don't put you on hormones. So for our purposes, we're going to kind of average that to that 10 years before you go through perimenopause, where your hormones are doing wild things. And there's a lot of symptoms there. So I group the symptoms into brain symptoms and gut symptoms because this is a gut-brain axis presentation. So that made sense. I excluded things that are obviously hormonal, like vaginal dryness. Yeah, that's just like low estrogen, right? Like there's nothing really fancy about it. So I kind of excluded those sorts of symptoms. And I'm also working on the assumptions, like you've already watched that webinar. Like you kind of know, hey, I could use phytoestrogens or progesterones. Like whoop-de-doo. So we're thinking about the other things, the other impacts those hormones have and ways we can modulate that. I also left out things like, I swear, people come in and they're like, yeah, so her joint pain could be a symptom of perimenopause. I'm just like, really? Like, okay. I don't have anything to substantiate that you're wrong, but that seems like a little bit of a stretch. But I mean, I guess I could logic my way there. So I kind of left out those sorts of symptoms too. So anyway, so this is our gut brain axis symptoms that you can kind of think about. I special shout out to insomnia, brain issues, and that irritability. Like, whew, those are rough, I think, in perimenopause, and I think they can be difficult to treat. So, okay, so that's perimenopause. I think we're all pretty comfortable there. So then we've got hormone status, and we need to connect hormones to the gut and hormones to the brain. So hormones and IBS. So this was complicated because I feel like our hormones do crazy things because we've got that kind of overall hormone surge with puberty, but then we have the monthly surges, and then we go down in the 40s, but then we also have like high hormone states like pregnancy and just like, ooh, and then lots of women are on like birth control. So it's kind of messy, and the research wasn't great. So I put the like, yeah, we know this for sure thing. So for sure, I pulled the stats. Women suffer from IBS in a 2-to-1 ratio compared to men. So for every one man with IBS, you got 2. So that's kind of a bummer for us. We also know that within that female category, the rates of IBS actually increase after puberty, and they decrease in their late 40s. I'm sure we all know what else does that. And then you've got your males who, contrary to that, they are consistent rates of IBS from their 20s till they're 70 years old. So I don't know what that has to say about andropause theories, but in terms of, well, how do we relate hormones back to gut health? We can see that generally more hormones are going to cause more fluctuations in your digestion. They're going to cause aggravations there. So this is where things get complicated. Okay, well, before your menses, when you have a low hormone state, so that sort of PMS phase, that week before, many women have things like bloating. They might have like loose stools or diarrhea, like that's super common. And we also see an aggravation in pain and bowel, like stuff in general. So if she's got like a pain syndrome, it's going to be worse before her period. So that's a high hormone, like a low hormone state within a high hormone state. And then you've got pregnancy, which is a really high hormone state, and things get better. And then a postmenopausal woman, okay, we know her IBS rates decrease. So it's like lower than low. So anyways, that's kind of messy, but we definitely know there's a very clear correlation there between hormones and gut health. Same thing with mental health. Okay, I think we all know hormones contribute to mental health. I think we've all felt that either personally or we know somebody who's like, oh yeah, it's a week before she gets her period and she's just like, oh, super irritable, or she cries like because you looked at her backwards or too nice or whatever. And so we know there's a huge correlation, again, clinically, between hormones and mental health. So what do we know for sure? Well, we know for sure that anxiety and depression rates increase in perimenopause and in menopausal women. So I think that's really important to note. So gut symptoms get better, mental health gets worse. We also know that if you have an early menopause or if it's surgically induced, you're also at risk for dementia or higher risk for dementia. So I think that becomes really significant too when we think about the gut-brain axis. What else did I have on here that I want to talk about? Oh yeah, OCD. That was a weird PMS thing. I don't see a lot of OCD, but it turns out that women who have a worse flare so they have a flare of OCD premenstrually, they're also more likely to be on an SSRI, to have worse ratings of anxiety, depression, and to be on other long-term psych meds. So it seems like the women who have the worst hormone states, so the worst PMS, also have the worst mental health. So I thought that was really interesting. Okay. So that's perimenopause. Now that you believe me that hormones influence both ends of the gut-brain axis, let's break that down. So we're going to talk about estrogen and progesterone. We're going to go through what we know for sure about them, which I don't know. It was actually less than I thought it was going to be that we're like, yeah, definitively this seems to be how it works. I think that's kind of frustrating, but maybe not unanticipated because you have hormone receptors on every single cell in your body, basically, right? And there's different types of receptors that we'll talk about, and different types of receptors have different effects. So I think there's that. And the reason we're talking about both ends of the spectrum, so we're talking about estrogen on the brain, estrogen in the gut, is remember, this is a two-way street of communication. I want you guys to be fluid, and you can start on the top and work your way down. You can start your way on the bottom and work your way up. And I think we all see that, right, with that patient. You're like, okay, I'm going to put you on the best gut treatment ever. That constipation is going to be resolved. You're going to do great. And you just hammer their guts for like 4 months and like nothing changes. And they come back and they're like, oh yeah, my primary put me on SSRI, my constipation got better. And you're like, oh, right. So we need to know when it's relevant to look at the other end of that axis as well, and like not just hammer the gut. Maybe we need to switch and go to the brain, or vice versa. So estrogen, anyways. Okay, so what do we know for sure estrogen does? Well, for sure we know that it increases motility, and it does that with two things: histamine and serotonin. So for histamine, it decreases diamine oxidase. That's the enzyme that breaks down histamine. It's a brush border enzyme. So it decreases degradation and increases mast cell stimulation. So you're going to be spewing out more histamine and not breaking it down. So that's going to move things along nicely. And then it increases serotonin. So, and decreases degradation of serotonin. Remember, serotonin's a big motility agent. So that's why you'll find 5-HTP in some of your motility products. Most serotonin gets made in your gut. I think I always like an excuse to tell people about this. Serotonin is responsible for nervous diarrhea. So if you got really excited about something, like, I can't eat anything, well, that would be why. So anyways, so we definitely know that for sure about estrogen. The other thing that I think is really, really important to know about estrogen that's pretty well substantiated is that estrogen really does impact the immune system at the level of the gut. So it plays a big role in barrier function. Specifically, it can cause increased permeability, and it also plays a big role in antigen presentation. Why is this important? Well, it's really important because, well, one, your perimenopausal women are having estrogen spikes. The other reason it's really important is because a lot of women in perimenopause specifically go on birth control because they don't want to deal with the heavy periods, and they don't want to deal with the craziness of perimenopause. Well, what is that doing to them? Well, all right. So antigen presenting. So the dumbed down version, or the simplified version of that without getting super like into the immune system, is your antigen presenting cells basically gather up fragments of stuff that they find. Those fragments, they're protein chains. That's what we call antigens. And they take it and then they put it out on their surface in different receptor types. So they've got receptors they put out with an antigen that says, hey, this is us. Don't react to it. It's totally fine. Everybody, hey, this is a piece of normal. And then they'll grab things and they say, ooh, this is not us. And they put that out differently and they say, hey, this is a problem. If you get a danger signal with that, that drives all your other immune systems a little crazy. They're like, oh my gosh, we got an infection. They start reacting to that, right? And so when we think about how does estrogen impact that, it's going to impact antigen presentation. Well, what does that result in? Well, we know that women who are on birth control pills, those like obviously not progestin only, so estrogen combined type, estrogen progestin based oral contraceptives, they're at an increased risk for inflammatory bowel disease. We also know that women are just in general more likely to have autoimmune diseases. And so this becomes really relevant because estrogen really plays a role here. And so many women are actually literally eating estrogen pills. That's about, I got the stats for you. It's about 14% of women in the United States age 15 to 49, which is about 10.7 million American women. And that's a fairly substantial amount. I pulled Canada too. 16% of Canadian women in that same age range are on oral contraceptive pills. So this starts to get pretty exciting. We think about what does estrogen do in the gut. It can definitely cause upregulations. So with, for instance, with IBS, you're going to be more likely to see more estrogen receptors. You can see more sensitivity in pain syndromes as well. So when she talks about that hip pain, maybe that hip pain that you're sensing, it actually comes from estrogen and activity in the gut. So anyways, estrogen in the brain. Okay, this was substantially less fun than estrogen in the gut. Just wait till we get to progesterone. That's even less exciting than both of these. So, all right, so ER alpha and ER beta. So with your receptor types and your hormone receptors, there's two different types. Your classical hormone receptors are going to be nuclear. So the nuclear ones, that's on the nucleus of the cell. So that hormone has to go inside the cell, sit on that nuclear receptor, and then that goes and starts triggering gene expression. So we associate those with RNA synthesis, like you're building things. So it's gonna be a little bit more of a slow response over time. The non-nuclear receptors, those are going to be much more rapid. It's not a genomic signaling pathway. It's more of like G protein activation. And if you're, again, not fun, like you don't like acronyms, there's like a bunch of pathways that help regulate cell growth, apoptosis, that sort of thing. That's what those receptors are more geared towards. The non-nuclear receptors are more geared towards activating. So it's going to be a little bit faster than that classic pathway. So with the estrogen receptor types, we've got ER alpha, ER beta. They do very different things. We really like ER alpha. We don't like ER beta and don't seem to do a lot of research on it in contrast. So the most important thing to remember estrogen receptor alpha in the brain increases hippocampal spine density. Well, what the heck does that mean? It makes your memory better, essentially. So this research was done in women with menstrual cycles, or rats probably actually. But what they saw is, okay, high estrogen state, better density, low estrogen state, less density. And so we can kind of extrapolate that out over time and into that perimenopausal phase of as she starts seeing instances of really low estrogen, you're going to have decreased spine density, you're going to have decreased brain function. We also see an upregulation when you stimulate ER alpha of acetylcholine transferase and release. And so that's going to just be more acetylcholine. We think about acetylcholine and, of course, memory. I like to think about it for executive decisions. And so we also then see increase in anxiety. I think that's not really surprising. More excitatory neurotransmitters, more anxiety. And then the ER beta, that's where it's like, doesn't seem to have the same impacts on memory. It's found in different places, so more in the hypothalamus, so might be more related to regulating our body and our circadian rhythm, which we all know can get really out of balance in perimenopause. And it does go up in natural menopause over time, which is kind of neat. And this one seems to decrease anxiety. So that might be part of a natural compensatory mechanism. We might shift our receptor types. I have nothing to substantiate that, but just a thought. So that's estrogen in the brain. And then the last thing we want to think about in terms of, well, what is estrogen more so on the brain side? But again, serotonin in the gut too, is estrogen can really change the way your body makes and recycles serotonin. So I like this diagram because it's not overly complicated. I've got the link down below if you want to read the whole article. I think this article is pretty good too. So you start with tryptophan, that's your precursor. You have to convert that into 5-HTP. That's typically if we're going to support serotonin supplementation, that's what we take. And then that gets converted to 5-HT. So that's your serotonin, right? So estrogen ramps up the conversion of tryptophan to 5-HTP. It also then decreases the creation of, so if you look in the green over on the right there, step 2, that is going to be that feedback receptor of your neuron being like, oh yeah, we're putting a lot of serotonin. Let's kind of self-regulate that, right? So you're seeing less of those, and then you're also going to see less MAO. And so MAO is that enzyme that breaks down serotonin. So now you're increasing production, you've got less feedback, and you're not breaking it down as much. And so that seems like a fairly significant ramp up of serotonin from estrogen in your brain. Then this is where things get fun. All right, numbers 4 and 5 on this diagram. Short-term estrogen exposure decreases SERT. What's SERT? Serotonin reuptake transporter. So that's the thing that sits on that basically vacuums up all the serotonin you just spewed out. Long-term exposure increases that. So if you have a short blast of estrogen, you're going to upregulate serotonin production, and you're going to decrease reuptaking it. So you're gonna have more serotonin sitting in that synapse for longer. If you have a lot of estrogen for a long time, you might see an actual increase in reuptake. So even though you're making more serotonin, you're vacuuming it all up back into that neuron. And so you might not actually see that effect of that serotonin. Maybe you'll break even, maybe it'll be like you have less serotonin. And I think that's something that's not well substantiated, and it probably varies wildly depending on the individual. Like maybe they're already really, like maybe they're really, really good at making MAO. So reduction in MAO, or maybe they're really bad at making it. So reduction is like, oh boy, that's a problem, right? And again, it's hard to know exactly what you're going to see there, but this is kind of that net effect of estrogen. I think when we think about that, that accounts for why we see a lot of different mental health impacts from our hormones and kind of through that perimenopause. Maybe it's irritability, maybe she's rageful, maybe she's weepy. There's a lot of variety there in what you might see. So that might explain for some of that discrepancy or that difference from female to female. Okay, so let's talk about progesterone. So I was kind of disappointed by how much we didn't know about estrogen in the brain and memory. I think I was even more disappointed about progesterone. So anyways, but I was already committed, so I had to talk about it. So, okay, so estrogen has the 2 types of receptors. We've got the nuclear and the non-nuclear, same thing with progesterone. So the ones we're thinking about here are gonna be the non-nuclear receptors, so the membrane bound ones. So the non-classical pathway fairly fast impacts. And so what is progesterone doing in the gut with those receptors? Well, progesterone in the gut, we know pretty well. The first thing we know for sure it does, and you literally talk to any pregnant women and you'll know this, progesterone inhibits smooth muscle contractility, which slows down motility. So you can think about progesterone, high progesterone, and constipation. So it's basically the exact opposite of serotonin or of estrogen in that regard. but it's not specific to the gut. So progesterone inhibits smooth muscle contractility in all the smooth muscles. So you can think about your vascular smooth muscles. Progesterone also has a inhibitory effect on them too, and can have a relaxation effect. And you also see that increased nitric oxide production from progesterone, which obviously we think about in terms of blood pressure, but nitric oxide can also be part of our immune system response. So that's kind of some neat bleed over there. We see decreases in permeability. So again, the opposite of what we think about estrogen doing. And then we have increases. This was hard to find, but for sure, increases in bifidobacter in late pregnancy. And when they cut out rats' ovaries to get rid of all their hormones and then just chose what they did, progesterone increased lactobacillus reuteri, BDNF, which is brain-derived nootropic factor, so improved nervous system connections, and it decreased their anxiety and depression. So that's pretty cool. And then kind of the sum total of that is like progesterone has a neuroprotective effect on gut cells. The research for that they used to figure that out, I thought this was worth sharing because it's kind of like, So they have enteric nerve cells, and they put them in a dish, and then they poison them. They want to model Parkinson's disease. So they poison them with rotenone. Rotenone is an insecticide and pesticide that was super heavily used, but it's restricted now due to environmental toxicity. But if you think about the demographic who gets Parkinson's, they're all old, right? So they've probably been exposed to that. So I was like, huh. Anyways, we won't tarry on that. You can dig into that yourself if you want. But when we treated those enteric nerve cells with progesterone, they saw a decrease in cell death by 45%. That's pretty significant, I'd say. And then if they reversed that by adding a progesterone receptor blocker, the effect was negated. It went back to like whatever the normal levels of cell death were from that treatment of that pesticide. And so progesterone for sure has a neuroprotective effect. We see that lead over into the brain as well. So progesterone in the brain, what we know for sure is that it has very well-established neuroprotective effects in TBI, traumatic brain injury. I knew that going to this presentation. I'm like, oh, for sure it can be good for cognition. Well, that's a little dodgier. So the research on this is not great. So, all right. So one of the issues with progesterone and hormone replacement therapies in general is, okay, so we want to see if a hormone makes a difference for a postmenopausal woman or a perimenopausal woman is we look at her native, we look at sometimes surgical menopause, and we might look at like postmenopause, like, and whatever hormones we add, there's a lot of variety in that. And typically we're seeing non-bioidentical. And like, for instance, do you guys remember the Women Health Initiative that was done like 20 years ago or so? And they gave a bunch of women Premarin, and then they stopped the study because they're like, oh my gosh, we're having too many negative events like cardiac events and strokes. And well, all right, well, you're giving a bunch of women Premarin, which is pregnant mare urine. So it's estrogen conjugates from horse pee. And they were really confused why that was going poorly. And I don't understand. So I think some of the issue that we see is not using bioidenticals. I think some of the issue is there's a lot of variety in how this research is applied or designed. So typically, if you look through all the positives, you look through all the negatives, and you try to gather that, like, okay, well, what for the ones that had a positive impact, what were they doing? So we see that if you hit within 6 years after menopause, you start taking progesterone, you saw increases in verbal memory and global cognition. So progesterone does seem to have an impact on cognition. Not well elucidated what that mechanism is. We do know that the progesterone metabolite allopregnanolone increases the activity of GABA, but I don't know that anybody's ever associated that with cognition. And that's kind of that's what we know for sure. Oh, I was going to ask you guys, maybe if you put this in the comments for me. So the ELITE trial, I wrote that up here specifically because that's like one of the biggest trials that was looking at hormones and found a negative effect of progesterone as part of your hormone replacement therapy on cognition. But they were doing vaginally delivered micronized progesterone 10 days out of every month. And I was like, what? Who does that? So I'm really curious if anybody out there is doing that. And this was the easiest way for me to ask the entire country if anybody's doing that. But I'm super intrigued, like, wait, what? Obviously we can use topical, but 10 days a month vaginally delivered was very interesting to me. So anyways, comment on that if you have anything. But anyway, so that's going to be what we know about progesterone. So neuroprotective for sure, GABA for sure, good for cognition sometimes in some forms. I would argue that if you're using bioidentical in combination with estrogen at the right time to actually support her, like as she kind of goes to that perimenopause and early menopausal timeframe, like, well, obviously you're going to get more impact if you give her some synthetics 20 years after she went through menopause, right? So anyways, okay, so those are the impacts of estrogen and progesterone on the brain. So now we're thinking about non-hormonal treatment strategies. I specify non-hormonal because I think perimenopause is fairly challenging. I think probably a lot of you don't necessarily have access um, to hormones and just giving her bioidenticals. And then a lot of women don't want that, or maybe they're at risk, like maybe they've had some sort of hormone sensitive cancer and we want to avoid using hormones. And so it's nice to have more than one tool to help with perimenopause and other sort of transition symptoms. So yes, I love phytoestrogens and phytoprogestins. But we're not looking at those. You can use those in combination with everything we're talking about here. I don't think anything would be contraindicated. And like, let's be real here. Like a lot of times you give her black cohosh and she's still like, I still don't sleep. And so we do need to know how to layer on as well. So now let's circle back around to our classic perimenopausal patients. So we're all on the same page here. So when we think about perimenopause, this is kind of like your standard patient. It's not obviously the sum total of everything you can see. But I wrote her up because I feel like it's pretty average. So she's got mixed type IBS where she'll have 4 to 5 stools in a day, and then she'll skip 3-4 days, and she just hates it. It's been kind of increasing worse over the past 2 years. Her sleep is atrocious. She wakes up every morning at 3:30. She's up for like 2 hours, finally falls back asleep right before her alarm goes off. And then she's obviously very irritable, some fatigue during the day, super low libido, like non-existent is how she describes it. And then her brain's not doing as well as it used to. Like she's got to write everything down or she'll forget it. And she starts kind of like getting distracted. Like she'll jump from, she's like, okay, I'm typing up an email, but then somebody knocks in my office. So I turn to deal with them. And then I realize I never took my water glass out. So I jump up and carry that up, right? And it's that sort of like squirrel brain. And then she notices that her periods really align with that too, where they're a little all over the place. Some of them are heavy, some are a little bit lighter. Maybe she skips a month here or there. So definitely just in the throes of perimenopause. So what's going on with her from a hormone level? This disaster. So in your normal menstruating phase, your hormones have a very predictable kind of rise and fall, and they move together. When you hit perimenopause, they decouple. And so what do I mean by that is that green line that represents your estrogen. That's highs and lows, and her lows are like low, and her highs are higher than anything she would have during her normal menstruating years. And so like talk about estrogen dominance. Oof. So when we think about what's going on in perimenopause, some of what we can blame for all of her random symptoms is high estrogen, just as much as it might be low estrogen. I think that's important to remember. And then we can also think about the estrogen to progesterone ratio. Well, that's super off too. So when you think about, hey, remember what estrogen and progesterone do in the gut? They kind of oppose each other, right? Where serotonin increases, estrogen increases motility and progesterone decreases it. Well, if you don't have those two balanced, you're going to shift one direction or the other. If your body's struggling to keep that balance, you might see some of that fluctuation in your gut symptoms just because of what those hormones are doing. And so we have to figure out, well, how do we work around those fluctuations to get her some level of normal? So sometimes it's helpful to think about the perimenopause types just as you as a clinician thinking about this. So the lady who tends to skip cycles and has light periods and is having hot flashes, she's probably more of a low state versus that lady who's having super heavy periods and maybe a more frequent period. And maybe she's a little bit more of a high estrogen. That can be like a basic way to look at that. We can also think about this in terms of, well, actually, let's do this first. If you want to investigate that lab wise, you can do hormone testing. That can be tricky sometimes to nail down, but if she's having a somewhat regular cycle, sometimes that can answer that question for you. Now, if we want to take this in terms of the gut-brain axis and see if we work on that, if that levels out some of those symptoms, we have to remember we've got multiple modes of communication. So I re-summarize them here. We've got the endocrine, which is for us, now we're thinking endocrine, okay, cortisol. We've got immune system, we're gonna look at histamine, and we've got our nervous system, so your neurotransmitters and your vagus nerve. And all of those interplay with your sex hormones. So that makes it a really, it's complicated, right? Anyone can be impacted by sex hormones, but anyone might also then go around and impact your sex hormones. So two-way street there too. Woo. So lab testing things, obviously we can evaluate cortisol by doing an adrenal test to look at that HPA axis and the neuroendocrine communication route. we can look and do stool testing. That's a great way to evaluate the microbiome and see, hey, do you see those shifts in your microbiome that we know we can get from estrogen? Are we lacking lactobacillus or bifidobacter? Do we see signs of other like negative shifts, maybe something more towards inflammatory and autoimmune? So that can be huge to work on the neuroimmune system, but also neurotransmitters and histamine. And then hormone testing, like I said, yep, can be tricky sometimes. So the other thing is I didn't write down, I thought about it after the fact, is I really like organic acid testing. And maybe I'm a little biased since that's one of the things I do consultations for, but I think it's neat because you get neurotransmitters and you get a few gut markers and you get some inflammatory markers. So I actually often use that in my perimenopause one, especially if I really just can't track down like when to test her hormones. It's like, well, okay, let's at least start there. That can sometimes be a really nice thing to look at. And maybe if you just do neurotransmitter testing and her brain symptoms are really bad, that might be something to think about. Or if you like to do, I don't know, there's lots of different ways you can do testing, but those were the foundational ones. So, all right, so let's look at these communication routes. So the first one I wrote down to me is the most foundational because literally I'll never let a lady go through perimenopause or even early menopause. She does not go through my office without getting put on HPA access support. And the reason is that you see, so with the reduction of estrogen, you see a relative hypofunction of the HPA axis. So I've literally never met a woman going through perimenopause who didn't need support for that system. I always think of it as like, hey, you know, your ovaries, they're quitting, so your HPA axis, your adrenals have to take that over, which isn't really true here. It's not like it's burdened by that production. It's the communication can get deregulated. And then with your high estrogen states, we kind of see that opposite thing happen where you're more sensitive to stressful stimuli. You have an upregulation of that communication. And so again, thinking about perimenopause where it's highs and lows, ooh, those poor adrenals are going to be like, so what are we? Are we high? Are we low? Like you're telling me to calm down. Now you're telling me to ramp up. And I don't tend to think of cortisol as being like that. I tend to think of it as a slow responder. I tend to think of it as it like that hormone functions best in a stable, predictable sort of environment. So if we want to optimize the HPA axis, there's a lot we can do here. So the first number one most important thing I do is you have to stop skipping breakfast and start eating regular meals. And I know intermittent fasting is another one of those like sort of trends. I cannot get behind this for women going through perimenopause. Why? Well, skipping meals is a stress on your body. And I don't think a lady going through perimenopause needs another stress on her body, but also because we can see an increase in her cortisol if she goes for more than 14 hours without fasting, which we don't really want to do if her cortisol is already like dysregulated. We want to help her stabilize that. We also can see issues with blood sugar in this time, and eating consistently can help your body balance that too. And so breakfast to me is super important. Prioritizing a schedule. I'm super militant about schedules. Like I just love schedules. They feel so good. I don't understand why everybody doesn't want to be a schedule. But man, some people are really resistant. Like, well, I want to go to bed when I want to go to bed. But that's really bad for your HPA access. And so we want to try to coax our patients towards a set wake time, a set bedtime, set meal times can be really helpful too, because then your body knows what to expect. It can start ramping up whatever it needs to do to deal with that thing, be it going to bed, be it eating food, be it exercising. And then there's other things that really can help reinforce HPA axis regulation, like sunlight exposure, especially in the morning. That's really popular right now, and I'm totally behind that. I love adaptogenic herbs. So this is part of my HPA access support for, again, every perimenopausal lady. And then you could also think about using things like phosphatidylserine, which helps resensitize your hypothalamus to the levels of cortisol. So if she's had high cortisol for a while, this can be a really helpful support there. And so this mode of communication, I think is probably the most helpful in terms of, hey, what are we going to do for perimenopause that's not hormones? Let's see here. So the next one we can think about is the neuroimmune. The neuroimmune system is going to be, I'm looking at histamine because I think that's the most obvious sort of communicator. Histamine is, it's hard, man, because there's so many different types of histamine receptors and people present their histamine dominance different ways. Like I've had patients who it's diarrhea and migraines, but then I have other ladies who it's like hives, like classic hives, right? It's like, ugh. So you kind of have to have a little bit of a clinical suspicion around histamine, but I want to draw your awareness to this is more likely to be an issue in that perimenopausal timeframe because of what we know estrogen's doing, and we know how that impacts your histamine secretion. So histamine, special shout out to the fact that I did not know this before I did this presentation. It is involved in sleep-wake cycle regulation. So I knew about it for attention, but I didn't realize it also extended to sleep-wake. And that's really important because so many women have insomnia. And so this might be part of the way you can help her with that, is thinking about, well, is histamine playing a role here? What else? So the other thing I like to think about for histamine, I don't think it's necessarily well elucidated in this situation, but when we think of, okay, well, what's estrogen doing with histamine? So we have a decrease in DAO. Well, estrogen can also cause leaky gut, which further decreases DAO. And so sometimes it's not just more estrogen, more histamine. Sometimes there can be layers to that of like, hey, you need some DAO, but we also have to work on getting that estrogen out of your gut. So you might think about working on the estrobolome to improve her histamine. It's not direct, but it does kind of two steps removed could it also improve her histamine secretion. And so there's a lot of layers to that one there. All right. And then, so the other thing you can do to work on histamine that I think we all kind of know, just work on our microbiome. So when we think about, well, what's the microbiome have to do with histamine? Besides, yes, okay, it can create leaky, or it can degrade your brush border, so you lose those enzymes. But specifically, you've got bacteria that can make histamine and some that can help degrade it. So I pulled this for you: microbial patterns in patients with histamine intolerance. So your healthy controls compared to your histamine intolerance group had much better alpha diversity. And then your histamine people had elevated levels of stool zonulin, so leaky gut, and they also had elevated levels of rosburgia. I've actually seen that play out really well. So I Thymoeffects test, right? And I had a patient who was literally allergic to water. She's like, yeah, I can drink water from, it was super random and weird, like a pure water filter, but not a Brita, or I can't drink the city water, but I can drink the well water. Oh, but I can also drink city water. And like when I went to St. Louis, I'm like, what? Super weird. And then blueberries one week, but not the next week. I'm like, okay. So we did the stool test and her rosburgia levels were really high, even though that can be part of beneficial flora, everything in balance, right? And so you can see some of that creating some of that histamine dominance. And so fixing up her gut is another way that we can work on that histamine and work on the neuroimmune pathway. Surprise. I'm sure nobody's surprised. Okay, so then lastly, we've got the nervous system work that we need to do. So, all right, if there's any chiropractors out there, you guys can be super excited because I'm about to give you major kudos. The nervous system is possibly the most foundational thing we can work on, and why the chiropractors care, because a good adjustment can reset your nervous system. So, okay, so when we think about the nervous system, we've got that vagus nerve, and we've got the two branches, the sympathetic and the parasympathetic. So the sympathetic is go mode, the parasympathetic is rest mode. So all of your activities of maintenance happen when you're parasympathetic, things like digestion and good sleep and good hormone secretion. And so many times you have a lady who comes in with perimenopause and she's telling you things that direct you not just the HPA axis, but a little bit deeper towards that nervous system. She might say something as specific as my nerves are just frayed, like everything rubs me, or I'm just super overwhelmed by everything all the time. Or my favorite, my body thinks everything is stressful. So she indicates, she can logic through, I'm like, I shouldn't be reacting to this, but she still does, right? And I think that that becomes really important to kind of recognize, like, oh, this might be a little bit deeper. And so the nervous system, remember that vagus nerve can talk to everybody, the brain and the gut at the same time. It bleeds over into the immune system. And so this becomes another really powerful route of intervention for the gut brain axis. And so for that lady in perimenopause, helping her figure out ways to tap into that vagus nerve to work on the nervous system imbalance. And sometimes that's, you've been anxious your whole life and maybe you've got some trauma, even lowercase t trauma, like, okay, you have to actually work on that. Sometimes it's supporting her, like teaching her how to, like, hey, let's calm down before bed, and like how to stop letting her brain run her. I like flower essences. I think those are lovely. Call me bedtime routine, binaural beats. There's vagus nerve stimulator devices. I've never used one of those, but they seem cool, right? So there's so many things you can do there. Herbally, it's gonna be your nervines and your bitters can also do that. And so that's gonna be a system that we really want to pay attention to and support as well. And it wouldn't be a Microbiome Labs presentation if we didn't talk about one of their products. So ZenBiome Sleep. I hope you guys are using this one. I like this one. So they didn't tell me I had to talk about any particular product at all. And I think Microbiome Labs, that's one of the reasons I like talking to them. They literally let me talk about whatever I want to. But I want to talk about this one because it's cool and it really fits here. So why I'm excited about this? Well, I'm personally excited about it because I've used this before and it was really great. I was in my first trimester of pregnancy and I was having really bad insomnia, which you'd be thinking, why? Well, progesterone surges, but estrogen surges too. And you probably can tell by now I'm fairly easy to upregulate and excite. So I felt that estrogen surge much more than that progesterone surge. And so I was waking up in the middle of the night, not sleeping, and Zenbime Sleep put it right back. It's like, whoa, that's cool. So that's when I started to dig into like, what's going on here? And there's a lot going on here. So let's break it down. So first we've got calm, like, okay, lemon balm, it's a nervine, it enhances GABA. All right. Theanine, and that also enhances GABA. It helps with good neurotransmitters. Okay. So that's going to be kind of more on that neurotransmission aspect. But as we start kind of putting those two together and slowing down that brain, and we look at the bifidobacter lungum 1714, that's kind of what gets really exciting to me. And like, yes, I know perimenopause is very different than pregnancy, but we still get that same dysregulation because we still have those major hormone changes. And you might remember way back in the beginning, I was like, ooh, hormone interaction with the gut-brain axis is very complex and it's not straight linear, right? It's like a low hormone state within a high hormone state, like premenstrual crashes, can still have profound negative impacts. And so I think that the same logic applies where, hey, sometimes you really need a product that talks to the gut-brain axis. So what's really exciting about this is it reduces cortisol output. So actually I have the graph for that. So what we're seeing here is that they measured cortisol in their placebo and their treatment groups, and we definitely saw less cortisol output in general. So that's exciting because if somebody's stressing, you want to make her less stressed. That seems like a really cool way to do that. But then what's interesting is the same bacteria also reduce daily perceived stress levels. So the HPA axis got better, but their mental like connection to that stress also got better. So that to me seems more sympathetic, parasympathetic. When you think about it, like I feel like I'm stressed or I'm not stressed or I perceive things as stressful, that seems more nervous system. So that gets me excited. And then, obviously the bottom of that, they saw that the outcome was that sleep got better. So and it's only 4 weeks, so that's pretty good. The other thing it does is I wrote down here, increases kynurenine. You're probably not familiar with kynurenine because I wouldn't unless I did organic acid testing. It is made from tryptophan, just like serotonin. So they're kind of in opposition to one another in that regard. Same precursor. Kynurenine turns into quinolinate and kynurenate. Quinolinate and kynurenate are inflammatory modulators. So you need to be able to make those if you've got a lot of inflammation to tamp that down and to temper it. So this improves your body's ability to make kynurenine, which means you're going to deal with inflammation better. So now we've got HPA access, we've got support, we've got nervous system support, and now we also have sort of that neuroimmune system communication as well. So I thought this product like just makes sense, right? Because it works on all modes of gut-brain axis communication. So that got me jazzed. And again, I actually use it and I actually like it in my practice. So in terms of what are your treatment strategies, you can focus on the gut. I think you all know how to do that. Specifically in perimenopause, we're thinking leaky gut, we're thinking histamine support, we're thinking supporting that microbiome because we know it's going to get hammered with different hormone influences, and that can really disrupt things. So specifically focusing on diversity. So that's why I would I most often use something like Omegaspore because that really does promote diversity over time. And then, of course, you can always work on that estrobolome too. I think that becomes pretty relevant because just because she's seeing low hormones and going through perimenopause doesn't mean she doesn't have issues with estrogen clearance. So anybody lady who had something like fibroids and they're getting better, yeah, no, you still have to treat estrogen dominance. And then, of course, your brain thing. So adaptogens, special shout out to maca and ashwagandha. They are so good at supporting sex hormones in addition to being an adaptogen that we literally don't use them in hormone sensitive cancer types because they're that good. So like this would be a great choice here. They're very modulatory, very in the middle. So that can be really nice if you're just trying to support somebody through. I like to use them in combinations to push it one direction. They're like, if I need to calm her down or boost her up, I'll use different blends, but I always like to see either maca or ashwagandha in that. Your nervines, I put hops first because hops is nice. It is a bitter, so it's good for digestion and for your vagus nerve. It's obviously a nervine, so it helps her calm down. It's a phytoestrogen, so it kind of leans in that way. It's also a muscle relaxant, so it can be really nice for sleep that way. And then, of course, classics that are gut and brain with nervy nerves would be something like chamomile or lemon balm. We can also think about if you want to get super specific with her neurotransmitters and you feel confident mucking around there, MAO support to help break down excess histamine, especially if she's anxious and agitated. Or you could think about if she's low serotonin from being low estrogen, you could do things like GABA or 5-HTP as well. And that's kind of the gloss. So what did we learn today? Well, we learned that the gut-brain axis communicates via the vagus nerve, neurotransmitters, the neuroendocrine system, the neuroimmune system. And we actually find that hormones impact all of them. So we can work on any or all of them that we want to create that perimenopausal treatment plan. I think it's easy to get overwhelmed when you think about that, but because they're all so interconnected too. But with the type of medicine we all practice, it's you can start with one and see what happens, and you might see positive impacts in other systems. And so you can kind of like slowly build on that treatment plan. And a lot of times what we find is that if you work on ones like we talked about, you can work on the brain or the gut, and the other one will get better. And I think that's a really exciting point of working with the gut brain axis with perimenopause. So that's what I got for you guys. And I think we'll take questions.
Thank you so much, Dr. Moreau. That was very full, very dense, and very exciting. It can definitely tell that this is a topic that you're in the right space. You are very passionate about this, and I'm so glad that you are out there helping women through this. We do have a few questions that came up here, and I have a few comments as well because I was definitely excited about some of the things that you talked about. So first, you may have mentioned this, but I think it's worth repeating. How do you like supporting symptoms of hot flashing and anxiety in your patients, both hormone and non-hormone approaches?
Anxiety is going to be, yeah. So hot flashes are typically going to be, honestly, both of those HPA access support first. So adaptogenic herbs, we know that there's a correlation between hot flashes and blood sugar stability is really hinged on your HPA access. So that cortisol pattern, but there's going to be a liver component to that too, right? So teaching her how to eat for blood sugar stability can be huge for anxiety and huge for hot flashes. And again, very often you'll see a woman, she'll flash first in the morning, or like as soon as she gets in bed and she like chills out, boom, she has a hot flash. And so, in those circumstances, there's a huge connection to what's going on with her HPA access. Further for anxiety, there's a lot you can do there, right? I think it depends where it's coming from. So I mentioned I like flower essences. Those are gentle medicines and they're slow. So I'll often start those right out and then layer other things on top of that. I don't use a ton of 5-HTP. I'm much more likely to do things like GABA. Sometimes I'll use CBD, not a huge one for me either. Like a theanine, GABA theanine blend can be really nice. And then that I use Zenbiome Sleep. I more often use it for not sleep. I use it more often for anxiety. Which makes sense, right? When you understand that mechanism, like there's nothing specific about that product to sleep. They just have to call it something.
Yeah. Well, and I think it offers a good alternative for some people who may not want to use something like melatonin,
Totally.
which is a lot of people. And do you ever use the ZenBiome Cope in for any of your patients with the saffron? Yeah.
Why? Because I don't get a lot of patients with depression. Um, I don't know. I'm just not in a very depressed area. I feel like I've practiced in 3 different parts around the country now. I'm like, I just don't get a lot of depression in my practice. So, that's kind of how I typically think of saffron. I think about it for neuroinflammation. So, yeah, no, I just like start using the sleep. I'm like, man, I like this. So I'm trying to use it for like a lot of different things. And I think that's pretty normal, right? Like you have your home run sort of things like, yeah, this is cool. So that's kind of like
They
what I keep
let you
that up.
know. Yeah. And
Mhm,
I'll just, share this with our audience is that saffron is one of these up and comers
mhm.
for balancing menopause and is these menopause symptoms. And additionally, that B-longum 1714 is also specifically studied for sleep. So there's definitely a lot of those benefits for sleep in both the ZenBiome Cope and ZenBiome Sleep. So yes, thank you. A few more have popped in here. Anne is asking, have you ever heard of anyone applying progesterone on muscle area and it decreasing inflammation? I definitely have some answers here, but I would love to hear what you say.
No, but I haven't used it that way. So that would be extrapolating that mechanism of being neuroprotective and extrapolating it outwards. No, typically I would use a topical glutathione in that circumstance. What are you seeing?
Yeah, I think you can use both, of course. Progesterone is quite anti-inflammatory. There's a lot of progesterone in the peripheral tissues and a lot of receptor sites. I've heard of it being applied for those TBIs and being applied directly on the head, on the neck, and helping with a lot of that. So we know that it also can help modulate our endocannabinoid system. So yeah, in that way, progesterone is pretty remarkable. But of course, it's not for everybody, of course, and there's different ways to modulate our progesterone system. So, okay, great, you guys. Thank you. This is awesome. The other question, you did mention a few things here, and you talked about mast cell stabilizing, and some tips around that. But again, worth repeating, what do you like to do when you see a lot of this mast cell activation symptoms around gut-brain axis and hormone imbalance?
Yeah, so I for sure will always use a DAO enzyme, and I typically would dose that like twice a day in acute phase, or maybe more like once a day for if it's like we're kind of through that first couple months, things are calmed down. I definitely like to use quercetin. I've had ladies who come in with their perimenopausal is like, I'm allergic to everything now, and I don't know why. It's like, ooh, and like you run a food sensitivity test, and it's like they literally react to everything. You're like, oh no. So I would use long-term quercetin and vitamin C in that strategy. So that lady I mentioned who like her histamine dominance is migraines and diarrhea. Like I know her, she's still an active patient. Like, yeah, she's been on quercetin for a while. Like it's really important. Um, yeah, she's interesting, right? Because she has certain ideas around things. Like she doesn't want an estrogen detox. I'm like, well, so
Yeah.
but yeah, so that's gonna be a big strategy for me. I do a lot of mold testing in my practice, so I always like to check that because that's one of those sneaky things where if you don't have a high level of clinical suspicion, you're gonna miss it. And that can really have a profound impact on some of those things too, because it's gonna obviously imbalance your immune system. And it's not always in predictable ways, like it can be different for different people and obviously overburdening your liver. So if it's not processing out what it like hormones and stuff, like oof, because it's busy with mycotoxins, that can certainly cause issues. I think about mycotoxins as like the ultimate like dead end of like, yeah, you recycle it, but then you reabsorb it, so you like have to process it again and again. And often when I test that in patients, what we see is they're fairly depleted, right? And so that can play a huge role when we get to perimenopause because a lot of those ladies are really depleted. They've been working hard, they've had kids, nobody cared about them, they didn't like manage themselves effectively, and so they're just like burnt. And so I think that kind of can be part of my patient picture that I often see.
Yeah, huge need for that. Those nervous system regulating tools. How about omega-3s or mega marine for histamine imbalance and mast cell stabilizing?
It makes great sense, right? Because like omegas are so good for balancing the immune system. They like shush everybody. Like, okay, calm it down, kids. So like I love omegas. I'm smiling because I I underuse omegas big time. And like admittedly, that's a fault for me of like, I should be reaching them to like everybody else use them like all the time. Like, why don't I? Like, I don't know. But no, they're obviously can be huge. And
Yeah.
I've definitely used those for some of like my like very imbalanced sort of patients. They can be really nice there. But you have to dose it fairly aggressively initially, I think.
Yeah, absolutely. Yeah, I always call it Mega Marine is kind of our surprise and delight kind of supplement, which has many pleiotropic effects. Another question here that came up, and you may or may not have some thoughts on this, but I think you touched on some of this environmental tools that we can use. So, thoughts or recommendations on EMFs impacting the gut-brain axis and nervous system regulation?
Yeah, some people are super sensitive to that for sure. Um, you're more likely to be sensitive to EMFs if you have a more histamine dominant situation. So it would not be unreasonable to think that she would be more sensitive to EMFs as she goes through perimenopause. Typically, for anybody who's struggling with sleep, you need to turn your phone on airplane mode and it's like, or off. Like I want it at like out of the room if we can. I that does not make a difference for everybody, but it's worth a try because for some people it's profound. I actually had a colleague who she's much older than I was, so she had two kids already, and she'd flip the breakers off every night for the EMFs. And one night she got home late from school, and so she didn't flip them. And her daughter like stormed into her room that morning. She's like, "Mom, you forgot to flip the breaker. I can tell because I'm more anxious." And she like storms out again like only a preteen can. I was like that's amazing. Like she knew it made her mental health different. And so for some people, again, I think it is profound, but definitely not for everybody in my experience.
Yeah, absolutely. And, anything we can do that is kind of a no-brainer, especially some of those low-cost moves, like putting our phone in a different room, turning it off, turning the Wi-Fi off, all of those things, I think we want to offer our patients, as suggestions. And because again, some of this stuff can get really expensive, as we know, and a little bit prohibitive. Um, so next question, I love this. What do you recommend for symptoms like IBS symptoms, gas, bloating in your menopausal women? So, she is asking, or this person is asking about Megagard versus Digestmate, which one might be better for digestive symptoms. This is specifically for somebody who has H. pylori, and they're addressing it with the family, but they have significant digestive symptoms.
Yeah. Oof. Um, that really, I feel like that really depends, right? You know, you're basically, hey, do we want to do like what level of gut treatment do we want to do? So to me, the minimal level of gut treatment would be something to kill bad bugs and something to repopulate the gut. That's kind of like your bare bones. But 9 times out of 10, I need something to also heal the gut, right? So I'm looking at something like your mega mucosa. And then sometimes it also makes sense to throw enzymes on top of that. Well, how do you know? Well, you could give somebody enzymes and see if they get better. If their bloating all gets better, then you know, okay, this was largely an enzyme issue. If it doesn't get better, then you know you need to work on their microbiome. So you can trial and error it that way. I feel like I always err on the side of aggression if we don't have testing to tell us what to do, and we want to. I like to get people better faster. So that's one area that I'm like, yeah, you're doing 4 gut things all at the same time. Like, good, because it's all synergistic, right? Like if you have something constantly tearing you apart and now you're going to go kill bad bugs, but they've got leaky gut, all of the stuff you're killing, remember LPS, it's all going to end up in your bloodstream. So we want to heal that gut layer. So I personally always do a month of gut healing before I do any nuking.
Mm.
And that is how you avoid tons of bad die-off symptoms, everybody. So
Yeah.
that would probably be my strategy there. Like, okay, you know you've got a lot of digestive symptoms. You know you have H. pylori, so stomach acid issues, infection. Yes, you can treat the H. pylori, but hey, let's think about healing things and then kind of restoring function. So kind of, I'm babbling a little bit now, but I also think about what's their stress level. If somebody's more stressed, they're more likely to need digestive enzymes. So if you're like, oh yeah, you're definitely a stress bucket, like get those enzymes going for sure.
Yeah, and that's such an excellent point about enzymes and stress. I think the Digestimate is kind of a no-brainer there. Will offer sort of immediate support. If we are talking about symptoms of H. pylori and confirmed H. pylori, definitely add that MegaGuard on top of that, in addition to Pyloguard and Mega IgG, as that will be a nice, well-rounded approach. I love, you can either do Mega Mucosa or IgG, but really handling that first, which will mitigate a lot of those other symptoms. But yeah, I think that I agree with you there. Let's address that first and get after it. So,
I like the
um,
IgG a lot, right? Because that hits everything.
mm,
Because it clears pathogens, it improves leaky gut, like it calms down the immune system. So like I do use that a ton. So that's a good thought of like putting that in first.
yeah, yeah, we we love IgG over here. I recently was at an event where I heard it described as it's like a, and maybe this is not the best description, but I think it's apropos. It's like a fine wine. It pairs well with everything.
That is
And
good.
this is not mine. This is one of our lovely reps who has been with this company for a long, long time. And so this is a fan favorite of ours. So I just thought I'd share that with everybody here. Okay, so we have another question from Anne. And we'll take about, yeah, we've got time for two more questions, Dr. Lindsay. Okay. Perfect. What type of suggestions would you have for long haul patients? Anything you know that can help? And I'm sure you've seen this, and I'm sure you've seen it impact a lot of the conditions that we're talking about tonight, impacting menopause as well.
Sorry, long haul what? COVID?
Um, so I would imagine that she's referring to long haul COVID.
Oh, I literally never
And
see
Anne,
long
you
COVID.
can confirm in the chat if you would like, but I'm going to assume that that's what you meant. Yeah.
Yeah.
Yeah, so yeah, long haul COVID, and some of those symptoms
Well,
and
and what you're thinking
how
about
you
with long
approach that.
COVID is going to be like you're stuck in an inflamed state, right? So the more inflamed you are, the worse everything is. So if that was my patient, the first thing I always do is organic acid testing because I want to see how those cells are functioning if I'm seeing deficiencies. The second thing I'm always going to do is I'm going to work on the gut, right? And so, okay, now layer that into perimenopause. So she's like, hormones are getting all out of balance, and we know she's super inflamed already. And as you lose those hormones, well, how is that perpetuating that inflammation state? And that's gonna be an area where it's like, well, do you do one thing at a time or do you kind of work on all of those things at the same time? I would probably work on the foundational things first and then see how much we can kind of round her out. And that depends on the practitioner too. Like, do you have access to bioidenticals? Does she want bioidenticals? Because sometimes those are really helpful and they just buy you that breathing room that you need to work on all the inflammation things. But typically we're thinking about the vascular system, the impact there. We're thinking about HPA access, and then I would argue detox is going to play a huge role there too. Like my favorite long COVID patient, she's a dentist, and she had pretty bad mycotoxins. Had a super old farmhouse because we've got a lot of those in my area in Wisconsin, and she's moldy, right? So of course you got inflamed from COVID, you never got better, but like it just decompensated you. COVID wasn't the issue, it was the trigger. So I always think of it in that regard.
Great. Excellent. Yeah, it sounds like just kind of starting with some of those basics and gut healing, something like a total gut restore. Yeah. Okay. Okay. And then Jennifer is asking about 5-HTP, and she's wondering about serotonin syndrome in those that take SSRI. So I think, did you recommend taking 5-HTP, or she's just curious about how big of a risk you think this is?
Yeah, no, not typically. I don't use a lot of 5-HTP in my practice. Typically I'll use it as part of a sleep aid if somebody's like really struggling with sleep. And that's going to be about it. General consensus is that you don't really combine it with somebody's on an SSRI. Like it's not prudent. Um, yeah, and in this situation with perimenopause specifically, we don't necessarily know what that serotonin's doing. So this is where it would be nice to test and quantify. Or if you're really good at nailing those clinical symptoms pictures, like, yeah, you can trust that. Like if she seems like she's low estrogen, truly low serotonin, like certainly you can support that, but I wouldn't do if she's on SSRI without like confirming that you still need more serotonin on top of that, right? Because there's many different things that can cause low mood, not just serotonin. So whenever there's a medication there, I always err on the side of caution. And like we do natural medicine, we have like 5 different ways to get the same thing done, right? So it's like, we don't need 5-HTP. Let's go a different route.
Absolutely. Well, we thank you so much. We are going to wrap up here, and just a few housekeeping um, things for you guys and items are next. Our part 2 of our Gut Brain mini keynotes is on August 21st, and that's going to be with Dr. Elisa Song. So the registration link is in the chat. It's also on the website. So go ahead and register for that. We're excited for that. And Dr. Moreau, thank you so much for your time today. We so appreciate your insights on this topic. And recording and slides will be sent to everybody. And I hope that everyone has a great day.
Perfect. Thank you.
Bye.